Oftentimes, people have questions. What is your suggestion if they need a little more clarification but don't know how to ask for that clarification?
Well, get a second opinion.
Hi, this is Charlotte. Welcome to the Cancer Caregiver Podcast. Let's get started.
Welcome to a special episode of the Cancer Caregiver Podcast. I have Dr. Robert Bard with me today. Dr. Bard is internationally recognized as a leader in the field of 21st century 3D Doppler ultrasound imaging and specializes in using it to detect cancers in numerous organs, including the breast, prostate, skin, thyroid, melanoma, and other areas. The images are used to accurately guide biopsies, target therapy, and provide focused follow-up after treatment. Dr. Bard's medical career began as a diagnostic radiologist and evolved into the practice of non-invasive 3D imaging with ultrasound, MRI, and laser technologies. He has served in the military, been the head radiologist at several leading hospitals, and published a multitude of textbooks and scientific papers. He presents articles worldwide, teaches at international conferences, and is on the editorial review board of national and international medical journals. Dr. Bard currently runs a private consulting practice in New York City. He appears frequently on regional television, national radio, and is a consultant to major healthcare organizations. He is committed to improving non-invasive cancer testing and developing minimally invasive image-guided technologies to prevent cancer spread through his foundation, the Bio Foundation for Angiogenesis Research and Development. In his role as director of Cancer Diagnostics, he lectures at Mount Sinai Medical Center, NYU Medical Center, and leading international hospitals in England, France, Spain, and Netherlands. Dr. Bard, it's an honor to have you here with me today.
Well, thank you, Charlotte.
Now, you have had such a wide-ranging career, from serving in the military to leading hospitals and pioneering cancer imaging technologies. But the question that I had while I was learning about you is, what inspired you to focus your life's work on early cancer detection?
When I was in medical school and in my radiology training initially, I was trained to do vascular imaging by sticking needles into arteries and looking at blood flow. Unfortunately, it was time-consuming, it was invasive, there was contrast, and then I was put into the military. And because of the 2-year hiatus as a radiologist for northern Thailand and southern Asia, I was able to see all the new things that were going on in the world, because in America, we have our own set here, but the rest of the world does things differently. So when I came back to America, I started working with radiology and transferred into ultrasound scanning. First, we looked at babies. And then, since we could see the head of a baby, for example, what else could you do? Well, you could see the placenta. And then later on, we saw that some of the simplest modes of baby ultrasound could be used elsewhere. Specifically, I was in the emergency room at Metropolitan Hospital. It's a huge city hospital in northern Manhattan. And somebody came in with a stab wound to the chest. So they suspected bleeding around the heart. And what I did was, the ultrasound couldn't see it, but you could use the A-mode ultrasound from the baby's skull. You put it on the chest, and then you could see that there was fluid around the heart. And that simple test saved the woman from undergoing heart surgery that she didn't need, and just having a needle stuck in and fluid pulled out.
Wow. So your experience overseas is what really started to inform you asking questions on how you can translate that back here when you came back to the United States.
Exactly. There are ways to do things here, and then there's, shall we say, out-of-the-box thinking, which is done in other places, because unless you live in a culture, you really have no idea what's going on. We are limited by our preconceptions, which are pretty good. Are in medical training, but then maybe there's another way. So there's got to be a better way. That's my motto.
Okay. I like that. And I think caregivers like to hear that too, especially when there's this sometimes gut feeling that maybe there's another answer or maybe different questions to ask in their diagnosis of themselves or the people that they care for. So I love that you present an opportunity to actually think that through, that there might be another way or something that maybe isn't always considered when we're talking about follow-up or second opinions. So for listeners who might not be familiar, what makes 3D Doppler ultrasound different from more traditional tools like mammograms or MRIs? Because I think that is one of the main tools that your center has really honed in on using it, especially for using it for early detection. Is that right?
Yes, when I started doing mammograms, women would come in, especially younger women with dense or lumpy breasts, and they could feel the lump, but the mammogram wouldn't show anything because cancer in the breast is white and dense breasts are white too. So white on doesn't work. It's like a polar bear in an ice storm. That's it. So it's really that simple. So then we started using regular ultrasound, and we could see things easily because a breast cancer in a white breast is black. It's so obvious that we gave some of the tools to the students now at college campuses because they put the probe over their breast, and if they see something dark in a white breast, they've got a problem. So the technology is simple. What made it better was we could see things better with using blood flow technology. In other words, if cancer is aggressive, it'll have a lot of blood vessels to it. And if it's minimally aggressive, which some cancers are, then it's got few blood vessels. So that's the blood flow. And then as we were looking at areas, for example, with the shoulder, the Germans developed 3D ultrasound, which they used on the shoulder. So I said, what else can you use it on? I put it on the breast, and the same technology, which takes 10 seconds to take 100 pictures in 3D, was being on the shoulders. It was being used on everywhere but the breast. It was using to see babies' faces. So now it's put it on the breast, and you can see the 3D image of the breast in seconds, non-invasively.
Yeah. And there's been more awareness of the issue of having dense breast tissue and how some conventional ways of looking at and doing diagnostic testing for breast cancer might not. And so having an awareness of the options for dense breast tissue is important. And especially since you have connected this to the issue of male breast cancer often being overlooked. And I just want for all of us to be able to understand as caregivers and patients with dense breast tissue, especially as how it correlates to finding male breast cancer, which a lot of people don't understand is actually a thing. How can we understand the complexities of a man getting tested for breast cancer when it's something that isn't necessarily taken into consideration?
Men don't understand that a lump in the breast means anything because the knowledge, the mindset of men is, first of all, I don't want it. I don't. And then to go into a women's clinic with 30 women waiting for mammograms as the only guy, it doesn't work. And worse is to have the compression of a mammogram on a very small breast. It's a turnoff because it's not diagnostic in a lot of cases, and it's too difficult, and men won't do it. That's the bottom line. Test that people will do, and then people will go for it as a screening technology.
Yeah. So I know for women, all women in the United States know that at a certain age, what is added on to your yearly checkups is to have to get a mammogram. So is there a certain type of man, is there a certain type of a history of things that are happening in maybe the females of their family that would cause them to need to consider also having imaging done? Or is it just when they happen to feel something? And is that too far into disease progression? Is there a way to maybe find it earlier?
Yeah, there are ways to find it earlier by screening, but let's go back a little bit. So, toxins and cancer. When I was training in the Air Force, they were using Agent Orange, and people were exposed. And today, currently, people are exposed to, burn pits in the military, fires from 9/11, which is a few blocks from where we live. So there's toxins everywhere now. And guess what? You drink plastics out of a bottle, guess where they're going? And plastics degrade, and they're now linked to disease processes. So screening is important because if it's easy, people will do it. If it's valuable, people will accept it. And then doctors will understand maybe this is the way to go, because we've shifted. China and Japan have shifted in the last 10 years from using screening mammography to breast ultrasound as the first screening technology.
Okay.
All countries. So people are beginning to be aware that it works. Secondly, because women are developing breast cancer at early ages, like 19, 20, 22, we've been seeing off and on for years. You have to realize that there's no early age that you can't screen at. So screen because it's non-invasive, it's quick, and it's diagnostic. The same thing with the men. If they feel a lump, you take the ultrasound probe, you put it on the lump, and you can show them, oh, it's a cyst, or some of the medicine you're taking is causing the male breast tissue to swell. So this is a way to test non-invasively, quickly, and accurately. What we do is we give the women and the men the probe and say, do you feel anything in your breast? Then they'll go over it. They'll take the probe and say, this is where it bothers you. And then we may guide the probe a little bit to get a better look at it. But patients want to know, because some cancers, specifically metastatic lymph nodes, move. And a patient will feel something, go to the doctor and say, no, I don't feel anything. Come back in 6 months.
Right.
But we give the probe to the patient, the men, the women, even the kids. You get the probe and say, this is where I hurt, or this is where my, this is where my itch is, or this is where it's irritating me.
Yeah.
They give them the probe and let them, it's their body, they know.
Right.
That's it.
And it helps them become part of the process instead of...
Exactly. They're included. So first of all, if they're included, you listen to them. Secondly, they have skin in the game, so to speak, because they realize something is being done that works, and not to avoid it, but saying, hey, we can go forward with this. This is not bad. Let's proceed. Let's listen to the doctor. Let's take the medicine. Let's do the test. Let's do the biopsy.
Right. And so the hard sell then would be for people who don't necessarily consider male breast cancer to actually exist. First of all, I've talked to a lot of people who were surprised to understand that men could actually have breast cancer. And because of how this is also starting to tie into the environment that we live in, you've started a screening program for firefighters, EMTs, and law enforcement. Why was it so important to start with them? And what risks do they face that many people don't realize?
Well, people who are exposed to toxins, especially the firefighters and the military and the first responders now, or people who were working in shipbuilding and in chemical factories, they're exposed, and they may not realize it. What's important is to know is there are easier ways to do it. This is a textbook from 2 years ago, Modern Breast Cancer Imaging. Guess what? They have a half paragraph on thermal imaging of the breast that's using heat to find breast cancer.
Okay.
And a half paragraph on elastography of the breast, which is used worldwide. All these technologies have been invented, but we're not using them in America because guess what? We have a way of doing it. 1, 2, 3, 4. Mammogram, sonogram, maybe, then biopsy.
Right.
Maybe MRI. The problems with MRI is, while they're good, there's a high degree of false positives.
Okay.
We'll get turned off. A guy will go to his doctor and say, yeah, I had one, but it was my prostate cancer, or found something in my in my liver that didn't need to be biopsied. So why? Need things people go for. Now, let's go back a little bit further. This is 2012.
Okay.
Another take on breast cancer. Oh, it's in French because after I trained in America, I trained all over the world and saw what else can be done.
Mm-hmm.
They are using ultrasound on skin cancer, on melanoma imaging instead of biopsies because you can see it immediately. You can see how deep it is. You can see if there's blood flow in it or not, if it's aggressive or not. And if it's a cancer, you stick the probe under the arm and you can say, oh, it's spread to the glands or not. And then if it's in the glands, you take the probe and stick it on the liver and say, oh, it's metastatic to the liver or not. In other words, you stage these diseases, melanoma, thyroid cancer, breast cancer, male breast cancer. It's all, it's in your hands of the operator. And this 3D imaging, it does things in seconds and minutes. Another thing about 3D imaging is because we can treat now. We've been treating tumors, the thyroid, breast, prostate with image-guided treatment. Specifically, we started off with prostate cancer with focused ultrasound, the same way they destroyed brain cancer in the brain. They did it 70 years ago. Ultrasound probes zap it with high-energy sound. It kills brain cancers or it cures Parkinson's disease. It works. We tried the same technology and we put it on the prostate. When you could shrink prostate cancer and destroy it with focused sound waves in minutes, this is great. And then we tried it on the thyroid and we destroyed thyroid cancers. And some people do it on breast cancers. There are ways to freeze breast cancers, for example, but you're left with a lump of coal. And it's disfiguring. You can use the minimally invasive treatments such as focused ultrasound, lasers now. You put a laser needle into something and zap it in minutes.
Okay.
3D imaging is important because with the 3D image, you hook it up to a laser tool or an MRI or a probe, whatever you're doing it, and you image guide it. You know where it's on the 3D picture, and then you can watch as the laser needle goes into the area, the breast cancer, the thyroid cancer, the prostate cancer, and watch it as it kills, as the tumor vessels go from this, down to this, down to this, down to nothing. Way of validating treatment without radiation.
Okay. So if someone is listening and is in a place where they want to know more about a health concern of their own or of a family member, and they reach out to your organization, what can they expect? If they go and they have diagnostics done and there is something that is found that is in agreement with whatever the oncologist that they've already seen says, it could be cancer, it needs to be addressed, then from meeting with your organization and then finding the results of the testing that you do there, what is the next step? Are you only diagnostic testing, or are you also connected to other doctors that then would move forward with the treatment that person would need?
The beauty of the imaging and image-guided treatment is if you can see a tumor, not only do you see where it is, but what it's doing. Remember, a lot of blood vessels aggressive, one blood vessel minimally aggressive.
Right.
So when you're treating, you have a way of following the treatment, because chemotherapy and even immunotherapies, they have side effects. A lot of times they work, but if they don't work, you have a way of following it and seeing that it's working or not working. We've also added therapeutic technologies such as pulse electromagnetics. In other words, the waves that you lie on, say if you have a pain in the back and you put the ultrasound pad on, the electromagnetic pad on, it heals the tissue. Guess what? It grows bone. It's been used on the astronauts to treat osteoporosis since space flight began. It's used all over the world. And it's not used in America because we give treatments for osteoporosis, bone to bone density, and you can use ultrasound on bone density too. It's done in Europe for the past 26 years.
Okay. And so when we're talking about those alternative approaches, right, from immunotherapy, and so those can fit alongside imaging and traditional treatments moving forward. You're saying that if someone is on a targeted therapy or chemotherapy and they want to see or track how it is or is not working, then using technology that you are focused on is a really good way to be able to see if something's working or not.
We tried to provide a full service, let's use options, because we see the tumor, it can be treated with the lasers or focused ultrasound or chemotherapy. The pulse electromagnetic technologies, which again have been used for 70 years worldwide and are recently being covered by the insurance companies, they reduce the side effects of chemotherapy.
Okay.
And whatever treatments we're doing, whatever minimally invasive or non-invasive treatments we're adding, they make it better and stronger because it boosts the immune system.
Okay.
Having a strong immune system is the key to everything, and we try to keep the immune system up with their various supplements, of course, technologies that do it, and we monitor the treatment technologies as we do it. For example, what's a way of checking things? You have high blood pressure, you check your pulse, you can feel it.
Right.
When the treatment is working, when we're giving image-guided treatment, for example, we check the vasculature. We put a probe on the pulse, look at the pulse pressure going up and down, and we can see if the treatment's working or not. Because if something doesn't work, then try something else, but at least you can visualize and see that it's working or not working well enough.
That's good to know, because oftentimes if someone is in treatment, this isn't always available to them to be able to do, and then to see that things are working or not. And if they are working, then having that better information to know, do I continue? Are the bad days worth it? So when you're having a particularly hard treatment that really affects your quality of life, then knowing that something is working can help you understand why you're doing something. But if you have a doubt, or if you don't know if these next 8 weeks of chemotherapy are actually going to do something, then it's really hard to continue through and comply to the treatment schedule because of not having that information. So that's a really good source of information to be able to have when you're in that position.
Yeah, and we encourage patients to be part of the treatment, ask questions, challenge the doctor, say, why are you doing this? What is this test for? Talk to us. We'll listen, and we need it because we're not gods. We need to know where else it's going. Specifically, I said the lump that patients feel that moves, it can be cancer. Usually it's not, but isn't it better to check for sure and find out what's going on? And because we have thermal imaging, we have non-invasive 3D ultrasound minutes. You walk into a doctor's office and you find out there's something wrong quickly. You don't have to wait 2 weeks or a month.
Right.
Mammogram report, or to get the biopsy back, then have somebody say, come back for more, or we didn't get enough. Really, it's like Star Wars treatment, quick, and it's being done all over the world. So I encourage patients to know that this is available. One last thing, this is one of the world conferences from Europe. This is the section, it's in French, but it's on treatment, and it shows, one of the articles shows that breast cancer can go from very low grade to quick. In other words, it's called interval breast cancer.
Okay.
A lot of people don't know about it. Even the hospitals don't know about it. Interval breast cancer. If you write INTERVB, it comes up. That's the next thing that comes up. Interval breast cancer. Why? Because from normal tissue, it can develop in months. 6 months. And it's called interval because it occurs within 6 months of having a normal mammogram and sonogram. And we see it now. So if patients get screening every 6 months, you find it before it gets really nasty and before it's spread.
Mhm.
Same thing with men. You can do the thermal screening of the breast. It's non-invasive. They get to take off their shirt, and it's something not degrading. It's something that men won't refuse to do. So unless you have cooperative patients, unless you have people who are saying, okay, it's worth my time, it's worth going to the doctor's office, make it worth patients' time so they have an incentive to do it, or they have less of an incentive not to do it.
Yes. And to be able to have conversations like this available to them, because I think even for women, the prospect of having to have a mammogram, especially your first one, the process isn't talked about often. And so to now share that there are different alternatives for them, especially if they know that they have dense breast tissue, for them to have this information and be a little more informed so that they can ask the questions that they need to, because oftentimes people have questions or they don't necessarily understand what's being said when they're front facing with the oncologist. And they often feel like they don't have the power to ask to understand. So if you were to hear that, a patient went into a meeting, not with any of your staff, but with a different oncology team and left not really understanding what was being said, what advice do you have as a medical professional? What is your suggestion if they walk in and they're finding that they need a little more clarification, but don't know how to ask for that clarification?
Well, get a second opinion.
Mm-hmm.
This is something I want to share. This is my 2014 lecture at Mount Sinai Medical Center for all the surgeons.
Wow.
And what I said was, a lot of people have cancer, as with our aging population.
Mm-hmm.
If somebody's got a lump anywhere, get it checked, because you can take the probe and put it on the spot and tell the patient it's a cyst, or my God, it's a recurrence. People want to know.
Yeah.
Any kind of certainty is better than uncertainty or not knowing. It drives people crazy.
Mm-hmm.
Affects the immune system. It's a bad way to practice medicine when you could do it now and people know it and can be done now. So get a second opinion. And
Nice.
like if you've had a cancer anywhere, just have it checked. They can put an ultrasound machine on any spot that bothers you and tell you, is it something serious or more likely not?
Yeah, that's good advice, to definitely go out and get that second opinion, especially now knowing that there could be other therapies that not all doctors know to suggest to have, or diagnostic testing. Before we go, I want to circle back around to the program that you're doing for the rescue community. So if there's anybody that is listening right now that's interested in knowing more, can you give us just a little bit more information about that program, the screening program for firefighters, EMTs, and law enforcement?
What we've done is ultrasound machines are portable. They're high resolution. We've sent one of our machines to the Los Angeles firefighters. The fires are still going on. There's toxic fumes everywhere. The doctors are calling up and saying, my God, I'm in the middle of, there are fumes everywhere. What's going to happen with my lungs? So during COVID, we learned we can screen the lungs for fluid or for irritation. The same, you put it on the lung and you see it either thicken or not thicken. You see the lung surface moving or static like a brick. It's bad. So you have ways of looking at contamination in the body, in the skin, in the breast, and finding it. We have ways, again, of sending probes out to the firefighters or the military or the police. Give them a portable machine that we gave to the college students who are scanning their own breast. They will run it over you, and if there's a lump, send us the picture. All this is wireless. It can be sent from anywhere in the world to groups or people like me who do the diagnostic reading, and they can tell you in seconds, hey, this is what's going on, or no, we don't like the picture, get a better view, or get another thing, or my God, it's serious. Get more testing, like get a mammogram or get something else.
Nice. I like that. So if there's anyone that is interested in learning more, or if there's anything coming up that you want us to know about, what would that be?
We are giving a global conference October 23rd and 24th on male breast cancer. So the Global Male Breast Cancer Alliance is having its conference, and it's showing the whole world what you can do. We're working with the Australians, for example, because they have sunshine, they've got skin cancer, they have all sorts of radiation from the sun because of where they live. These people are exposed and they don't realize it. And the exposure to radiation that you don't understand, like out in space, or the people in airplanes, they're exposed to cosmic rays. They're at high risk too. So people are at high risk and they don't realize it. So get checked now.
Yeah.
We formed a teaching program to teach people who are interested in learning in the medical communities globally. It's called the Angio Institute. It's a nonprofit foundation to help people. Everything is available. Just Google it, or Bard Diagnostics.
Okay. I'll make sure that all those links are in the show notes for this episode and in the newsletter if you get it. Thank you so much for being on here with me. I really appreciate having this conversation and allowing other people to hear about the diagnostics and the importance of, really staying on top of your health and getting the information you need. So thank you so much for being here.
Yes, thank you for spreading the word.
You're welcome.